are so excited to introduce Dr. Skop to come speak with us today. She was an OBGYN for 30 plus years, delivered thousands of babies, and she is the head of she's the head of medical research at the Charlotte Lozier Institute. So she's spoken in front of Congress, and she just has been doing some very exciting things. So we're really grateful to have her here today. Give it up for Dr. Skop.
Thank you, Rachel. It's great to be here with you guys today. And I hope to educate you on some things that I really did give a lot of thought to. And I do want to have a spirited discussion afterwards. So I hope that I will trigger some questions, and if you don't agree with me, that's fine. Let's just talk about things. I'm a Christian, but I am not going to formulate this discussion based on my religious views. I want to formulate this discussion based on science, based on medicine, and human rights. So I hear that there may be a few of you guys here today that are interested in the field of medicine. I think that's great. Even if you're not necessarily interested in pursuing a career, it's important to all of us, right? I mean, it affects us all. And so I think that hopefully we can just go back to the brass tacks and have this discussion. To start, I think we really need to have a good definition of what is health. The World Health Organization defines this as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Healthcare, along those lines, is maintenance and restoration of the health of the body or mind. Disease, disease is a condition that impairs normal functioning, typically manifested by signs or symptoms. And so in the realm of healthcare, our goal is healing, and healing is making whole, or the restoration of right relationships. So as you know, the topic of this discussion is abortion is not healthcare. So hopefully by the end, I will have convinced you of that, but if not, again, we can have a discussion about this. I definitely welcome that. So let's go based on those definitions, and now let's discuss the definition of abortion. Harvard Medical School, very prestigious institution, defines abortion as the removal of pregnancy tissue, products of conception, or the fetus and placenta from the uterus. So what is problematic about that definition? If I do a cesarean section at term, that fits that definition. So that's the removal of pregnancy tissue from the uterus. The American College of Obstetricians and Gynecologists, ACOG, is my professional organization. And unfortunately, the leadership of this organization are pro-abortion. They really have not discussed it with the membership. It turns out that only about 1 out of 10 obstetricians will perform an abortion if they're requested by their patients. So for most of us, we don't consider abortion to be health care. But ACOG says that the definition of abortion is ending a pregnancy with medication or a medical procedure. But again, I think we can see there's a problem there as well. If I do an induction at term, that's not an abortion, and yet it would fill that definition. I am a board member of the American Association of Pro-Life Obstetricians and Gynecologists, APOD, much smaller organization, but we have a different perspective on this from ACOG. Our definition is drugs or procedures used with the primary intent to end the life of a human being. So I think the two things, and if y'all see any problem with this definition, let me know, but the two things that are critical about abortion when we're discussing our terms is the intent is that the baby is not born alive. A failed abortion is one where the child accidentally escapes and is born alive. So the intent, I think, is critical there. Now, part of the confusion is that the medical definition of abortion actually does not distinguish between the two. So medically, an abortion is any pregnancy loss that occurs in the first half of pregnancy, so up to 20 weeks gestation. So of course we need to define our terms there. A spontaneous abortion is a loss that occurs where there was no external action, it was a natural loss. So a miscarriage, ectopic pregnancy, molar pregnancy. So what we're discussing here, induced abortion, is where there's an external action that causes that pregnancy loss. Sometimes we'll see, I think we will all admit, there's a lot of euphemisms, there's a lot of confusing language wherein we're discussing this topic. And one thing that I've seen commonly is conflating the procedure that is used to empty the uterus with an abortion itself. For example, in the first trimester, I can do a suction aspiration, what we call commonly a D&C, dilation and curettage, or I can use mifepristone and misoprostol. Mifepristone blocks progesterone. Misoprostol, usually given 24 hours later, causes uterine contractions. So either one of those will empty the contents of the uterus. So those are morally neutral actions. But again, I can use that D&C to care for my patient who's tragically lost her unborn child. But I can also do the D&C to end the life of that child who's living and would, if absent outside intervention, go on to be born. Second trimester, similarly, a dilation and evacuation. The D&E is the surgical procedure that's used. It is, because of the development of the fetus, a dismemberment procedure. Ideally, if this is being done to perform an induced abortion, it should be preceded by feticide. That's an injection of potassium chloride or digoxin to stop the baby's heart. If it's not given, many times later abortions are done through induction. And so if the baby is not, his life is not ended through that antenatal injection, then many times he will survive that induction and be born alive. And then if he is not cared for, then he is left to die by passive infanticide. So again, the procedures themselves are morally neutral, but it's the intent of the procedure that we need to be discussing. So what is within the woman's uterus? What are we talking about here? The reality is there is no scientific controversy about the fact that this is a human life and that induced abortion is his life. 96% of biologists, regardless of their political affiliation, affirm that human life begins with fertilization. So for those that are science nerds like me, you will recall sperm with 23 chromosomes impregnates an egg, which also has 23 chromosomes. Those are identical to the parent, but when they combine, we've now got 46 chromosomes. We have a genetically unique human being. He's human, his species is human, his parents are human, there's no controversy there, and he's alive. Because we define life as having a cellular structure that is an organized being, processing energy, metabolism. Having a stable internal environment, that's homeostasis, and growing, eventually the capacity for reproduction, and responding to stimuli and adaptation to the external environment. So none of that is controversial scientifically. Where the controversy lies is a philosophical question. When does that human life have value, and when should we protect it? Now, everybody knows that the oldest ethical tradition in medicine is the Hippocratic tradition. And this can be summarized with the phrase, first, do no harm. There are components of it that are no longer recited at medical school graduation. For example, I will not give a deadly drug to anybody who asks for it. So there used to be a prohibition against physician-assisted suicide. I will not give to a woman an abortive remedy. Again, used to be a prohibition against abortion. And I will not have sex with my patient. So that's the only one that is still commonly agreed upon. So medicine in general is having a little bit of an identity crisis. Some of y'all may remember the show from quite some time ago, Marcus Welby, Indy. When I became a doctor, this was my idea of what medicine would look like. So he was a kindly, skilled doctor, and he would give his patients advice on what he thought would be the best medical treatment for them based on his knowledge and his knowledge of the patient, getting to know the patient, making a recommendation of what he thought would be best. But sadly, today, I call it the vending machine model of medicine. There's pressure on us that if something can be done through a medical procedure that as a physician or healthcare provider, I think kind of tells you what the ideology is leading to. They tell us we must provide whatever that action is that the patient requests or demands. Obstetrics has the privilege and sometimes the burden of a two-patient paradigm. So we have two patients whose needs we must consider and balance. And fortunately, most of the time it is easy to make that balance, but sometimes it's not. Sometimes there are situations where we recognize that, one of our patients is going to be in a situation because of the other patient. So we have to really sit down and think about how do we do the best for our patients. Obviously, abortion, as we discussed, ends the life of one of our patients. When we look at the principles of medical ethics toward the unborn patient, we see that, of course, abortion does not fulfill any of those principles. Beneficence means we have an obligation as a physician to act for the benefit of our patients. Non-maleficence means we have an obligation not to harm our patient. Autonomy, of course, is important, and everyone should have the ability to exercise their capacity for self-determination, but this is not absolute. Obviously, one person's autonomous actions that injure another should not be allowed. Justice is fair, equitable, and appropriate treatment of all persons. So obstetrics is the medical field concerned with the care and delivery of pregnant women. So looking at that healthcare definition that we talked about earlier, it's the maintenance of pregnancy, prenatal care, delivery of babies. These are all forms of healthcare based on that definition. But disrupting a normal physiologic process, ending an unborn human's life, is the antithesis of healthcare based on the definitions that we've discussed. And it's infrequently discussed, but there are a variety of adverse outcomes for the mother as well following abortion. Emotional. One of our surveys of women with a history of abortion documented that 10% described their abortion as coerced. 14% described it as unwanted, and 43% described it as accepted but inconsistent with their values. Of those women, 60% said they would have preferred to give birth if they only had more material support, relationship support, financial support. So we see that for so many women, abortion's not what they want, but it's what they feel is the best option they have available. So that's an opportunity for us as a society to do that. There are more immediate physical complications than you may be aware. I think it's important to know that in the United States, there is nothing about abortion data that is mandatorily collected on a federal level. We don't even know the numbers of abortions. State health departments tell the CDC what they think. Some states refuse to provide any data to the CDC. The Guttmacher Institute is the research arm of the abortion industry, and consistently every year they report 30 to 50% more abortions than the CDC knows about. And now that drugs are being mailed in the mail, we have no idea. No idea how many abortions are occurring. We don't know how many complications. Again, that is not mandatorily collected either, and we don't know how many deaths follow abortion. As I'm sure hopefully you're aware, most abortions these days are being performed with medications, mifepristone, blocks progesterone, so it cuts off the hormonal support for the unborn child, followed about 24 hours later by misoprostol, induces labor, essentially causes expels the pregnancy tissue. Most abortions in our country are paid for privately. Most women, understandably, don't want to talk about it. And now, women are being told that if they should need to seek emergency care, that they shouldn't tell the doctors because they might be prosecuted. And so many of these women will not give that information to the doctors. So the doctors are at a disadvantage. They don't know how exactly what's going on, what it is they're treating. Our research has documented that 84% of women who come in with a known complication following a chemical abortion are actually miscoded as a miscarriage. So just a few statistics to help you understand just how bad our data is. We can get better data from European countries. Over there, single-payer healthcare generally pays for elective abortions, and in some of those countries, they're very meticulous record keepers. So we can look at the abortions that are paid for, and then we can see what kind of subsequent events happen. After these early abortion drugs, we see that about 15% of the women experience hemorrhage. Almost 7% will have retained tissue. Their body can't expel the tissue. This causes about 6% of them to require surgery, often in emergent situations. 5 to 6% are seen in an emergency room. About 2% have infection. 1 to 3% it fails entirely to kill the baby, and they have an ongoing pregnancy. Serious adverse events, which sometimes when you look at FDA data and you look at abortion industry data, that's all they count. These others they don't really consider to be that significant unless it causes a woman to be in the hospital, require transfusion, IV antibiotics, ICU admission, things like that. Even those are about 1%. Surgical abortions appear to have less complications, about 4 times less, but if a complication occurs, it can be more serious because of instrumental damage, possibly perforation of the uterus. Mental health complications are common. Again, we don't exactly know how common because this is very difficult to research. But studies have documented higher anxiety, depression, substance and alcohol abuse, self-harm in women following an abortion. These can lead to deaths of despair, suicide, homicide from an intimate partner, often in the setting of a relationship going south, perhaps after a coerced abortion. Accidental deaths, substance overdoses. Those European studies that I mentioned document that the mental health death is 6 times as common in the year following an abortion than if a woman had given birth to her child. So it's happening, but we really don't have the ability. Often a death certificate doesn't know about the abortion, and so these deaths are often not detected, they're often not analyzed. Women can have complications in subsequent pregnancies. Surgical abortions are linked to an elevated risk of preterm birth from damage to the cervix or to the uterus. The placenta can form an abnormal attachment. It may be too tenuous, what we call placental abruption, where it separates early, or it may be too invasive, placenta preta spectrum disorder. And both of those can result in catastrophic hemorrhage at the time of delivery. It used to be the case that when women had a pregnancy loss, that they were consistently tested for Rh negativity, and they were given a RhoGAM injection to prevent future pregnancy complications. But recently, based on very little evidence, the industry has decided we don't need to do that anymore, and so women in the first trimester are not being tested. So we don't know. This may lead to future severe pregnancy complications. And of course, sometimes the complications are severe enough that infertility results. And our research has documented that about 1 out of 10 women who abort their first baby never have another pregnancy. Maternal mortality, we're hearing a lot about it. It's heartbreaking. I think regardless of how we feel about abortion, all of us care about maternal mortality. But what we are not being told, often we'll hear a statement such as, abortion is safer than childbirth. They're looking at that incomplete CDC data, which, as I mentioned, if a mental health death is 6 times as common following an abortion, and we don't have any way to document that. I sit on a maternal mortality committee, I see the charts, I know that we can't detect those. So this is not a comparison that we can make, and it's really dishonest. But what we do see is that in the patient populations that suffer the most with maternal mortality, which tend to be Black women and often other minority populations, these populations also have the highest abortion rates. So in many cases, it clearly is not protecting them, and yet sometimes we will see people promoting abortion to these groups, saying this is the only way that we can protect you, is to help you end the life of your child. Going back to ACOG, I mentioned earlier, my professional society. Again, sadly, it's really the leadership's ideology that promotes, that causes them to promote abortion, but they do say that safe legal abortion is a necessary component of comprehensive health care. They follow a one-patient paradigm. So they tell us that we only can consider the embryo or the fetus as our patient if the mother gives us permission. They've called for advocacy to oppose and overturn all restrictions. And you might imagine that some restrictions do improve safety for women, but for them, access to abortion trumps the safety for the women. And that, sadly, we're seeing so many women working. This is collateral damage to this promotion. We're in fact, as obstetricians, told that we cannot have a conscientious objection to abortion, and we must refer for it, even if we're not going to perform it. But when you look back, you see that, again, this is not based on science, but what it's based on is a long history of eugenics, paternalism, and sadly, population control. Drove it prior to Roe v. Wade in the late 60s and 70s, and hopefully you all realize we actually are having a demographic collapse right now, because none of us are reproducing ourselves. No, barely any countries in the world are, which has its own set of problems, but the problem is not too many babies. You may have heard a statement such as abortion is evidence-based healthcare. So this is taking it up a notch. So what does that mean? Evidence-based is a very structured and disciplined method of determining whether a medical intervention is valid. And it has an acronym that they follow, PICO. P stands for a patient that has an illness or disease, which is targeted by an intervention, the eye, and then is compared to other available treatments or to no treatment, and then is evaluated for effectiveness based on objective, measurable outcomes. So maybe you're thinking, what disease are we treating? And that is a problem, because that has not been defined. So the best available studies are called randomized controlled trials. In medicine, the Cochrane Review Database is the organization that looks for all the trials, brings them together, and the answer is we cannot call this intervention evidence-based because no one has defined the illness that we're treating, and no one has randomized so that we see, does a woman in an unintended pregnancy, does she do better if she carries to term or if she aborts? And I think it's also intuitive to recognize that women's desires for their pregnancies often change over time. So if a woman doesn't have an abortion, she's going to grow to love her child, and so anyway, so we can't say it's evidence-based. Again, this is not a disease, it is a normal physiologic function. And of course, a pregnancy can become complicated, but just being pregnant is not pathology. It's important, I think, also to think about the reasons that women have abortions. Going back to those data deficiencies, only about 8 states actually collect the reasons. So we don't know the reasons for all abortions in our country. But from the ones that do give us data, 0.3%, 3 out of 1,000 are performed because of a threat to the mother's life or a major bodily function. 2.2% are performed for other less serious physical health concerns. 1.2% for an abnormality in the baby. So this means that 96% of abortions in our country are performed for social, financial, other undefined reasons, but not for medical reasons. Guttmacher Institute, again, they report data for the abortion industry. They tell us the same thing, that 74% of abortions are performed because a child would interfere with education, work, or the ability to care for dependents, 73% because the woman could not afford a baby, and 48% because she did not want to be a single mother or was having relationship problems. So again, we're implicating the fact that half of abortions in our country, half of the over 1 million unborn lives that are ended every year, are because the man who participated in the act of creating the child is not willing to be a father. Abortion for the life of the mother, I think, is important to discuss. We've all seen this in the news with the allegation that states that are protecting unborn life are somehow going to not be able to provide quality care to women. Well, I'm in Texas, I can tell you that is not the case. It is sometimes the case that we need to end a pregnancy to treat a severe pregnancy emergency. The good news is, most of the time when that happens, it's in the second half of pregnancy when the child can survive the delivery. So my job as an obstetrician is to deliver him in an indicated way that will resolve the mother's pregnancy emergency, and then I can hand him to my neonatology team, and usually they can save his life. Remember the definition I told you of abortion. That was the intent, the direct intentional killing. There have been times I've needed to deliver babies extremely early when I could predict that they would not survive due to prematurity, but I have never needed to intentionally kill my unborn patient in order to save his mother's life. And the good news is every state with pro-life protections has an exception allowing doctors to perform whatever intervention they feel is needed in their reasonable medical judgment, which means use your common sense and your clinical skills. So we shouldn't be reading about the confusion, and for most states it is clearing up, but unfortunately there was a little bit of confusion because sadly many of the pro-abortion medical organizations didn't really want to explain the law to their members and doctors outright. Prior to Roe, so again, more than 50 years ago, obstetricians told us this. Alan Guttmacher was the president of Planned Parenthood when they began doing abortions after Roe, and at that time he said, if a woman says she wants to be aborted, then we simply act as a rubber stamp and do it. So he knew that these were mostly preferential. Robert Hall, another obstetrician involved in opposing abortion legislation, said there are virtually no medical indications for abortion. I would place the doctor in the role of a technician, simply wielding the curette. If that was the case 50 years ago, you got to figure it's probably going to be less the case now with medical advances. So I do want to leave some time for questions, so I'll go through this next relatively quickly, but the American Medical Association, again, a prestigious medical organization, while they also are somewhat pro-abortion, but I'm going to look at some things they've said regarding other aspects of medicine, and we can look to see, does abortion fit any of these statements they've made. In their Principles of Medical Ethics on Informed Consent, they tell us that a patient must be able to understand the relevant medical information, that we need to provide the diagnosis, again, what is the diagnosis, the nature and purpose of recommended interventions, the burdens, risks, and expected benefits. So again, we need to have better data so we can tell women how often are complications occurring. And they tell us that the level of detailed information and time obtaining informed consent should be proportional to what is at stake in that specific medical decision. So we can see if a woman goes to a dermatologist to have a wart removed, that can be a very short informed consent. But in this case, we're ending a human life. So we should be doing a much better job than we are on informed consent. Prior to the Dobbs decision, the only abortion limitations that were allowed to stand were what are called, they call them TRAP, or Targeted Regulation of Abortion Provider Laws. Mostly these were laws that had the intent to improve the informed consent. So this would be something like a waiting period, so a woman had a chance to kind of take a deep breath and think about what she wanted to do. It was parental consent for children, so that a young woman didn't make a decision without her parents' knowledge that really could impact her life. Information regarding embryonic and fetal development, pre-procedural ultrasound. So all of those were extensively opposed as unnecessary, but again, they all had the intention of improving informed consent. Today, we're in the Wild West, in case you guys don't know it. The FDA, during the COVID pandemic, removed the in-person dispensing requirement for abortion drugs. So now people can get on a website, they don't even have to be a woman. They can just order them, and often there's no pre-abortion testing being done. So it's been documented all over our country that women are getting abortions at much later gestational ages than the 10-week cutoff that the FDA has set, that men are ordering these and they're forcing women in their lives to have abortions that they don't want. Sex traffickers are getting a hold of these. I mean, it's really off the rail. And you can imagine, is there any informed consent on this website? There is absolutely none. Going back to what I told you earlier, 60% of the women with a history of abortion would have preferred to give birth if they knew about the pregnancy centers here in Durango, if they knew that there were people that wanted to take care of them, walk alongside them, and support them. The AMA also lists 7 criteria that they say these are the criteria to help you as a physician define healthcare for which physicians should advocate. So let's talk about that, and then we'll end. Transparency. Have y'all heard the statement, abortion is safer than Tylenol? That's untransparent. Again, data deficiencies, we don't really know. Obviously, they're used for different reasons. No one's ever put them head to head. But what they're actually referring to is that Tylenol overdoses kill about 600 Americans every year. And they're saying, well, we don't know about that many deaths after mifepristone, so there, voila, abortion is safer than Tylenol. So that's not transparency. Includes input from all stakeholders. Obviously, there's one stakeholder who's being ignored in this, and that's the child whose life ends. But who else? Women who've been injured by abortion, those who regret their abortions or were coerced into abortion, children who survive abortions. There's an abortion survivors network of adults who were survivors of abortion. We should advocate for healthcare that protects the most vulnerable patients and populations. Well, obviously, the most vulnerable is the child who can't protect himself in his mother's womb, but also abortion targets historically disadvantaged groups. So there is a prenatal diagnostic testing has led to a search and destroy mission of children who are less than perfect physically and intellectually. Sadly, Black minority populations have been targeted. Their abortion rates are very, very high. It's estimated that over 20 million Black Americans have died through abortion since the time of Roe. This is the number of Black Americans that were living in our country during the civil rights era. So it has really decimated that population as well as other minority populations. Sex-selective abortions, we tend to think about that as, well, that's an international problem, India, China, perhaps. No, it's happening here. And again, vulnerable women, those who don't want abortions, but feel like society, for too many years, has made this the solution for all women's complex problems. Well, you know, if you get yourself in this situation here, you can hurt your child. We haven't taken care of her problems that got her into that situation in the first place. We've just merely offered her that one single option. So it's allowed us to be crazy and not really address the problems that women really face. We should advocate for healthcare that considers the best available scientific data. We talked about the data deficiencies. There's always objections whenever a law is passed that wants to improve data collection. We see science being ignored. Very good neuroscience right now tells us that by about 12 to 15 weeks gestational age, a baby has the ability to feel pain. And yet organizations like ACOG say, you know what, actually it can't happen until the cerebral cortex is nearly fully developed in the 3rd trimester. So babies can live at 22 weeks. We've all seen pictures of them in the NICU. ACOG says they don't feel pain. They don't feel pain until they're 28 weeks, 6 weeks later. Obviously, showing that their ideology trumps any knowledge of science. Similarly, we've seen a lot of states that have prohibited abortion at the time of a fetal heartbeat, embryonic heartbeat, and we've been told that, well, that's not really a heartbeat. It doesn't count as a heartbeat until the heart is fully formed with 4 chambers. But for that 6-week embryo, there's an electrical impulse that is causing contraction of the cardiac musculature, and it is propelling oxygenated blood throughout his body. And if that heartbeat stops, he dies. I mean, that's a heartbeat by any definition. So again, denying the science for ideology. I mentioned earlier that mifepristone blocks progesterone, and some women do immediately regret taking mifepristone. And when they do, they search online, they will find a provider who's willing to provide progesterone. So we know that in the same way that Narcan can reverse an opioid overdose, we can give progesterone to compete for those receptors, and we can improve that child's odds of continuing to live from less than 1 out of 4 to more than 2 out of 3. So science-based, women do change their mind. This gives them a choice to have a second chance at their baby. And yet, the mainstream medical organizations have called this unproven, unethical, contrary to science. You may be aware, here in Colorado, you have a law in the books that says that doctors cannot do this. And in fact, the Colorado Medical Board has threatened to punish doctors who do. So, a couple more things. We should advocate for healthcare that seeks to improve health outcomes. But what we see, again, when we look at the populations that have high rates of abortion, they tend to have worse outcomes. So their maternal mortality is higher. They have maybe increased mental health complications, preterm births in those populations with higher infant mortality, which, as I mentioned earlier, preterm births can be related to surgical damage from abortions. And the biggest thing that I think we've all probably noticed is that the narrative that abortion is a woman's choice has led so many men to say, not my problem. So if she makes the choice to have abortion, fine. If she makes the choice to give birth to her child, fine. And either way, he walks away. And so what we've seen is that prior to Roe, 1 out of 10 children were born out of wedlock in our country. Today it's 4 out of 10. In the Black population, it's 7 out of 10. So we've increased the number of single moms living in poverty who, of course, are at risk for all of those adverse outcomes. Healthcare that we should advocate for, monitors for variations in care, and yet we've seen many inner city populations, largely minority, Philadelphia, Washington, D.C., etc., where labor and delivery units have closed, and yet they've passed expansive abortion. So in those places, it's so much easier for a woman to get an abortion than it is for her to get quality health care and delivery. And then finally, abortion or healthcare that we should advocate for provides for ongoing review, adjustment, and based upon what we're seeing. But as I mentioned, there's really little evidence to collect good data. Abortion operates outside of the standard medical system. So whenever a state wants to maybe pass a law saying you need to have hospital admitting privileges so that you can take care of your complications, those are always objected to. One reason for hospital admitting privileges is so important is that doctors will be screened in order to get those privileges. So this is a way of monitoring to make sure that this is a good quality provider. So someone who may have lost their privileges in another state, this is a screening process. But we don't see that. We often don't see state medical boards or departments of health really supervising. And I think, if we paid attention, we've seen stories of many women who have been harmed by very, very poor quality providers. So I'm going to end by just contrasting two models of medical care. The dominant model, we call it the biomedical model, is sort of related to the American desire for expressive individualism, prioritizing our psychological desires, above all, fulfilling those desires as the pathway to human flourishing, often centered around sexual expression, the desire to, have abortion as an option because we want to be able to express ourselves in any way that we want. But I think that increasingly we're seeing that that is a deficient model. It's leading to so much anxiety, depression, angst within the population. And so I think we need to reconsider a more holistic, expansive model. We call it the biopsychosocial spiritual model. Again, this is born out of a Catholic tradition, but I think that many of us, even without religion, could see the utility in this. Oriented toward the basic goods: life, health, work, play, marriage, friendship, family, personal integrity, harmony with the divine. The spiritual dimension, of course, is important in this model, but being in Colorado again, I'm reminded of just how transcendent this state is. I mean, to walk out to see how beautiful nature is and to be in communion with nature, this is part of the spiritual. So again, rather than focusing on merely what can we do with medicine, I think we really need to reevaluate where we want to be, what is best for people, and that's to focus on this more inclusive model. So that is the end of my prepared statements, but as I said, I would love to field questions from any of you guys.